So I have no disclosures. Tried to be as good as I can with off-label. So who am I? We at Mayo have a CLL disease interest group clinic. We see about 250 to 300 new diagnoses a year, and we have about 3,500 plus individual visits, not unique patients, but individual visits. So I'm one of the clinical guys that have been there for the last 19 years in conjunction with the rest of our incredible group. So I'll try to relate to you kind of how I approach and where I am right now today with some of these issues that we've just heard about, and I'm learning. I think we're, in the last 2 years, everybody who's in CLL and everyone who's in oncology is learning this disease over. So just to kind of point out the timeline of CLL drugs, I got thinking about this, I went back. You notice that chlorambucil, 1957, down to ibrutinib, Idela. The good news is we're seeing more approvals, but that's the timeline of CLL drug approvals. So similar to what I believe one of our prior speakers mentioned, when you look at outcome over time, the classic RI classification was described in 1975. Tate Shanafelt from our group looked at our database about in 2009 and showed the same thing that was just presented with the Benet work of Dr. Malika, in that we are seeing improvement in survival, and it's not so much in the low rise stage, but it's in the higher rise stage, the people who need treatment. This is also a tabular form of something very similar you just saw, showing that the relative 5-year survival has continually increased through the last few decades. And I'll point out that, this is prior to the a lot of the chemoimmunotherapy, or while chemoimmunotherapy came on board, and it's prior to any targeted therapy. So what this means to you in the clinic and to me is that there is going to be a clear increase in the prevalence of patients that we're taking care of with CLL. We did an incidence study in Olmsted County, published 2 years ago, showing that the incidence of CLL and MBL has not changed, so we're not seeing a per population increase, but our prevalence, and I don't have the study to prove that, but I think we can say is going up. This means that we are going to see more CLLs, and nothing that we've presented or will be presenting today clearly has been shown to decrease the multiple complications of autoimmune cytopenias, Richter's, infection risk, hypogamma, second malignancies. And so in addition to managing the side effects of newer agents, we have to remember that these patients are a subgroup of cancer patients who have multiple other propensities. Proverbially now we have to have a BCR receptor signaling slide in our talks, and so there's mine. I think the important thing, number one, until we have studies that prove early intervention with any agent is beneficial, the indications remain classic. B symptoms, marrow failure, progressive symptomatic nodes, liver, spleen growth, autoimmune complications. Doubling time, yeah, you can use doubling time, but never use one value. Many of it, you can see it go from 120 to 150. The first question I ask people is, did someone give you a cortisone injection for your bad hip? Oh yeah, how did you know? So remember, doubling time is a fickle thing, but on the other hand, we have farmers. They don't want chemo this time of year. So if we're looking like last fall and then they're doubling and it's obviously going to need treatment, I say, hey, we can opt into treatment. So you can use it, but it's not a mandatory type thing. And as far as fatigue and that, yes, CLL doesn't make you feel better, but be cautious not to treat something that's non-CLL with CLL therapy. So this is just, you'll see several of these charts, and these have been developed by our CLL group at Mayo for our regional practices, ourselves, and they're just kind of go-bys in terms of how we do that. I know my slides can be shared, so I'm just saying that, again, early stage, there's no clear role for early intervention. If they're higher risk, then closer observation, clinical trial. And you will see some very early stage patients with autoimmune cytopenias, and then we may treat more towards the cytopenia. Initial therapy. So I was telling someone right before this meeting, and we've talked about some of these studies already. I believe in the power of the patient. And Dave, across the street from Mayo now, we have a Jimmy John's. And so, like, I'm sure no one, does anyone get a lunch hour in medicine anymore? No, an extended lunch hour is running to Jimmy John's, getting the sandwich, and getting back and doing our EMR work. So I was trying to watch carbs, and so I was like, I'm going to be good. I'm going to do the unwich. Now, if you really want, so there's just lettuce, no bread. So then I'm going to go and say, okay, I'm going to do the vegetarian unwich. Until this week, I realized it had almost 250 to 300 calories more than the roast beef unwich. So I do like roast beef. So my point is that we don't know. What you've heard from the two speakers already is we don't fully know. We can't fully predict where some of these things are going to be going. Yes, we have treatments that are easier, maybe kinder or gentler, very effective in the signaling agents. We have treatments with proven benefits with some side effects in chemoimmunotherapy. And does anyone here know exactly? My biggest question is, can patients with targeted therapy be salvaged as easy with non-targeted therapy as we can salvage chemotherapy-treated patients with targeted therapy? No one knows that answer. And so what I believe is like Jimmy John's. I actually print out this form when I'm having a therapy discussion. I take it in the room and I say, this is where we are right now. And I give it to them. We mark it up and I say, clearly at the top of there, FCR has the best complete response rate and progression-free survival, and has the 1/3 of patients at 10 years still in remission. BR has a very great response rate. Its progression-free survival is shorter. So if the toxicity is what we're needing, I put in for historical FR and PCR. I don't use either of them really anymore. And you can see that their progression-free survival doesn't really put them in the limelight, so I'm probably going to take them off my slides soon. Then we go to the bottom where we have the obinutuzumab chlorambucil versus rituximab chlorambucil and the ibrutinib, the RESONATE-2. And so I kind of look at where is the patient in age, what do I want in toxicity, because clearly FCR has more toxicity, but it has more benefit. And I kind of go through with the patient and say, for you, I think these are the choices. So I've had patients who say, I do not want to take a pill, and I don't say the rest of your life, I say with ibrutinib indefinitely, because we don't really know. We may find, so I use that word. But I've had patients say, Doc, I don't want a pill, and they're in their 70s, late 60s. Obinutuzumab is a great regimen. It doesn't have as high a progression-free survival, but it's very well tolerated, although I do find that I have to dose reduce the chlorambucil portion of that fairly significantly. And yet an ibrutinib, as you've been told, has a lower CR rate. Who knows over time what will happen with the MRD? So I basically say these are our options. I'll work with you if I think something isn't an option. They've got a they have a creatinine of 2.5. Well, ibrutinib isn't renally cleared, so that becomes my first. But I think the patients need to know and have a menu, and they can then, as best we can, honestly say these are the options. You've seen this slide, the FCR long-term. I won't go on that any longer. The only caution we have, and we heard this from the one speaker this morning, or this afternoon already, is we don't have a lot of time. The RESONATE-2 was based on 18-month data is a major point. It's a good study. I've already prescribed it, but I've also prescribed Obina, and I've also prescribed FCR in the last 3 weeks. I will tell you that Insurers have a lot of control. About a week ago, I prescribed ibrutinib as an upfront therapy. Aetna denied it. I called them. I said, I can save you trouble. This has been approved. 10 minutes later, they came on and said, I see what you're saying, but our forms aren't updated yet. So therefore, you still have to write a letter of appeal.
Painful.
And this was kind of alluded to too, but I want to just say CLL is a long-term disease. We have people, and our goal is to get them to their median life expectancy. So this is from Dr. Rye's original chlorambucil fludarabine study showing that at 6 years or so when they published, there was no difference, but over time, the curve separated. Because it depended on, the reason there was no difference early is the salvage therapy was usually fludarabine. So again, we have to be careful that we can't be too dogmatic until we know for sure salvaging. Idelalisib and Rituxan in treatment-naive patients. It's been reported by Dr. O'Brien and group. It has a reasonable response rate. Progression-free was reasonable, but a significant number of LFT abnormalities, diarrhea. This was presented at ASH by the Dana-Farber group, I think Dr. Jennifer Brown's group, and that basically upfront Idela and ofatumumab, the study was stopped early because of a higher incidence of immune toxicities, liver, especially requiring significant immunosuppression, probably related to the fact that more treatment-naive patients have more normal Treg function. And subsequent to even making the slide, Gilead has suspended several early intervention or early trials because of this. And we mentioned that the two American groups, the intergroup alliance trial has achieved accrual, and the ECOG, this was from about a month ago, is within about 50 or 60 patients of meeting accrual. These will be very important to show similar, very effective therapies, and also I'm looking not only for response rates, but how are we going to salvage people who fail? Are we able to salvage these folks? These are very important studies. So as I did for untreated, and I won't go through this, it's there for you to make a copy of or whatever. These are kind of our algorithm for younger patients, and you can define younger, but whether they're fit, they're frail, or they have autoimmune complications. This is our kind of go-by-it Mayo for the older, and again, they're not necessarily listed in order of preference, but I'm just putting there that this is the menu to discuss. In relapse disease, this is a slide my colleague Wei Ding put together. I think we can say more definitively that targeted therapy outperforms chemoimmunotherapy for relapse disease. Initially, there was a lot of resistance from folks. I want to use BR, but the problem is, if you look, see if I can get this to work. Well, if you look there we go. If you look under BR, you look at a 15-month progression-free survival. This is in previously treated. We're using it as a salvage. And you can see that all of the other agents, 2 approved, 1 is still not clinically approved, beat the PFS for bendamustine Rituxan. So that really targeted therapy should be your front line for recurrent disease. Obviously, differences in side effects, differences in relapse, differences in Richter's, but this, I think, I put this slide up to say that targeted therapy is what we should go to for second, third, fourth line treatment if possible. This therapy is related to the FISH cytogenetics, so that those with 17p have a more adverse median progression-free, about 26 months. And I have heard from Bill Weirdo that the progression-free for 11th Q is going to be about 38, 39 months, but I have not seen that, so that's only hearsay at this point. Idelalisib, this is the study from Dr. Furman showing that it is an active drug when combined with rituximab, 81% overall response rate. And maybe not quite as durable as ibrutinib, but some of the patients who respond to this respond for a long time, and not everyone gets the toxicities. So this is my go-by, or our go-by for recurrent refractory disease. And in terms of from ASH this year, things that were reported or recent studies, venetoclax is kind of the new kid to be on the block, the ABT-199, the BCL2 drug, showing high overall response rate of 79%, 20% CRs, so we are getting more MRD negativity. It is associated with tumor lysis, and they're using now a ramped-up dosing to cut down the risk of that. There are Richters showing, again, they could have been there. We're not saying that it is necessarily causing it. I think where we're going is in this next, there were multiple talks at ASH of combinations with rituximab, obinutuzumab, BR. The data is so premature that I just say that's, I think, where we're going, but I didn't present it here. Acalabrutinib is a second-generation BTK, looking very active, reported to have a fairly low side effect profile, and is going into, it's in a phase 3 study now. So with all these things, how do we manage these folks? Well, basically, if we look at the old chemotherapy, we had neutropenia, nausea, vomiting. Then with some of the newer, we started having the atypical infections, your pneumocystis, and now we're dealing more with the bruising, diarrhea, rashes, etc. This is just a comparison slide for your information. I won't go through it, listing indications, and for ibrutinib and Idela, this was made prior to March 4th, and so now the ibrutinib is approved for all CLL. As I mentioned, there are still multiple complications that we need to be aware of. The infectious, the non-infectious, the second malignancies, the autoimmune, in addition to any side effects from our new oral agents. A few cases. These are real cases in the last literally about 3 or 4 months that I've gotten calls or seen. 69-year-old patient, previously diagnosed with CLL with 17P. We did not treat him for 18 months. By October, he progressed. He had stage 3 disease. We recommend he start ibrutinib. It was advantageous for him to get it through the veterans. So we referred him to a VA hospital near us, and not the University of Minnesota. I'll just say that I don't want to make any. And within about 2 months, he was referred back to us for having failed. He had failed because his white count was now 243,000. And you hopefully already know the answer. He felt good, he had no complaints, and this slide has previously been showed that there is a lymphocytosis associated. We wished him his best and informed the VA hematologist in this smaller place that we were just fine. A 72-year-old male I saw about 6 weeks ago. His wife is a retired OBGYN. He had relapsed CLL and severe and multiple squamous cell carcinomas of face, head, neck, which will probably kill him. He had chronic candidiasis and was therefore put on fluconazole, ibrutinib, and I underlined the fluconazole there as a hint. Ibrutinib was started in August. He had a good response. In November, he had a pulmonary nodule. They were worried, could this be squamous cell? They arranged for a CT-directed needle biopsy. Ibrutinib was continued along with fluconazole at full doses, and he had a significant hemopneumothorax with drop in hemoglobin. Why? Well, we have to understand there are many drug interactions that you can have with ibrutinib, and we need to be very careful, and it does cause more bleeding. So this is an abstract at ASH looking at the first 90-some patients we put on ibrutinib, and we put our PharmD look at their charts pre-treatment. What we found is that, or before I go what we found, strong CYP3/4A inducers will increase the dose of, the effective dose of ibrutinib by up to 20 to 25-fold, I'm told. Inhibitors may suppress the dose. Inhibitors based on the degree of inhibition will also increase it, or reducers may lower. Other potential interactions are anticoagulants, aspirin, the NSAIDs, fish oil, herbals, SSRIs, grapefruit. What we found is that 63% of the patients we were to start on ibrutinib were on concurrent medications that did increase the risk of toxicity. 4% were on those that may decrease efficacy. So basically our approach is, if you're starting ibrutinib and you can stop an interacting medication, do it. If you can switch to an alternative agent, so an alternative blood pressure medication, an alternative antibiotic. If not, moderate inducers, we drop as per package insert to 140 a day. What do you do on a patient with severe fungal disease on posaconazole who we want to treat with ibrutinib? I've gone as low as once every 2 to 3 days and still get the rebound lymphocytosis and signs of response. Bleeding risk may be better with direct thrombin inhibitors, but this may be a reason for us to consider idelalisib or venetoclax or obinutuzumab, etc. The bleeding risks are about grade 3 or higher at 6%, and I always make sure the patients know they must stop the drug 3 to 7 days pre and post surgery. I've had several patients treated elsewhere have significant bleeds post-op. I'll just go through this quickly in terms of time. This is a platelet defect, and this is a beautiful abstract from the Vienna group at ASH showing that if you assess ristocetin cofactor activity, and as long as it doesn't fall below 25 units, there's very low risk of bleeding. If lower than 25 units, there's a higher risk, but also that it recovers within as little as 48 hours. A couple other quick cases before we finish. A 66-year-old male with coronary artery disease and CLL, responding well to ibrutinib, but developed AFib at 420, 280, and 140 milligrams with sequential dose reductions. He was switched to Idela with a PR. Atrial fib occurs in 6 to 9%. It may respond to appropriate therapy or dose reduction, or may need an alternative. It becomes an issue when dealing with cardiologists. What about systemic anticoagulation based on CHAD scores? And so that's an issue we talk about. Another drug interaction. 61-year-old male, hypertension, mild, controlled with hydrochlorothiazide, and relapsed CLL. He was treated with ibrutinib starting May of 14. He was a snowbird, as we called him. He wintered in Florida. He started getting high blood pressure in Florida. No one keyed on the fact he was on ibrutinib. They added metoprolol, which probably is okay, diltiazem, which further increases his level. And so basically we had him stop diltiazem and send him back to his primary care doctor. Hypertension can occur in 6 to 17%, and it's not immediate. This is an area that we're also getting into. A 68-year-old ophthalmologist with relapsed CLL for about a year. Patients over time may develop more myalgias. He was well-read. He knows all the patient advocacy issues, and he's a great advocate. And he decided, and about a few weeks ago, my nurse got a call from Biologics, one of the pharmacies that handle this, and say, you need to update your prescription. He's not taking 3 a day, he's taking 2 a day. We go, we didn't know he was taking 2 a day. Well, he had self-reduced the dose. His myalgias are better. And so compliance is something with long-term meds we have to be aware, regardless of what we say, may not. Dose modifications and compliance, the arthralgias of any grade are about 16%. It does seem to show up more later. And on the bottom there, you'll see the recommendations from the package insert or prescribing information. I take issue a bit with under CLL, with toxicities to restart at the same dose. Things like myalgias I will, but certainly bleeding or other major things, my credentials, my license I protect, so I often will drop to the next dose level. And one, if I can go back there, one thing I really think will help us is if we can get BTK binding assay to say, if we reduce the dose, are we still in the therapeutic range? That would be a big help to us in managing this. Finally, this is a case we had recently with a patient who's had multiple pretreatments. We finally, at the bottom of the page, started her on Idela. 5 weeks later, severe abdominal pain, CT negative, LFTs initially negative, over several days, progressively increasing LFTs. On a third repeat CT showed pancreatic edema consistent with pancreatitis. It was the New Year's weekend. We had a hard time getting an EGD. But so the question was, is this some kind of idelalisib issue or not? Turns out she actually had visceral zoster with duodenal lesions. And finally, about 7 days into her visit, she finally developed the cutaneous lesions as well. To say that we do recommend, I was talking with Jennifer Bound a couple weeks ago, using prophylaxis for PCP and varicella zoster with, or herpes with Idela. It's an active agent. You have to use careful monitoring. That's well outlined in the package inserts, and it is good for those who you have worries because of atrial fib or bleeding. This sums up the debate. Where we are right now with ibrutinib is in the canoe. I have some worry that we're going to have some rapid times ahead. And this was already mentioned, I won't go over it, that patients can progress very rapidly after discontinuation. More rapid if they're progressing, less rapid if you have to stop it for some other reason. I want to remind us that this ibrutinib was approved in February of 2014. So with the blue arrow I've inserted there, you show where we are now if we started a patient that day. So we will be seeing more resistance. We will be seeing more people progress. That's not a reason not to use it, but we have to develop strategies of how we're going to salvage. We find that in the on the right bottom paragraph where it says response to next therapy, the bottom line in switching inhibitors, ibrutinib failures to Idela 40%, Idela failures to ibrutinib 50%, or non-kinase about 40%. So we have a real ways to go with salvaging. Venetoclax looks very active. This is stuff from Jeff Jones showing a significant response rate, 53% PR and 40% as stable disease on ibrutinib failures. The mutation testing was mentioned during the question and answer. You can get it commercially, I'm aware of, with 2 labs now, from Ohio State's reference lab and from NeoGenomics. Ohio State's costs about $3,000, NeoGenomics around $800. There's no rule yet in doing it routinely, but we have been starting to see that some patients seem, and we found this in some of our protocol patients from PCYC 1112, 1117, that they have periodic CAT scans, and we've started to see where nodes tend to grow, or they may go up and down, or spleen may a little bit, and so we're starting sometimes to do a mutation testing before there's a clinical relapse, and we are now seeing, we have 1 or 2 cases where nodal progression actually started before systemic progression, and they were positive for the cysteine residue. And so it will, I think we will use it, but we're still determining when. And the final slide is for just to be aware of, there needs to really be standardization to what is Richter's in these patients. We have seen a number now of patients seen at NCI-designated cancer centers, and we all feel our hematopathologists are the best, but there are differences in what's being called Richter's, what's being called progressive CLL, and obviously for clinical trials, it has major issues. So hopefully hematopathology can help us to standardize which is which in this time. Thank you very much.